she passed recently part A from Malaysia, I think. Malaysia, or you go to Bangladesh?
I went to Bangladesh this time,
Yeah.
sir. Last.
We have one in the group, in our part B group, I think, or part A is from Bangladesh, but we don't know what happened to him. He need to continue us or not. Okay, so we can see later.
Thank you,
Okay,
Dr.
thank you. Is oh,
I might not be really good at this because
okay. She is the first time to join us. In Egypt, I think the exam in Egypt. So I think is the day before the exam he must be relaxed, because you know that it is exhausting exam. It is 18 station, and usually some countries or some doctor like in Egypt and other countries, they don't use to work 3 hour continuous. You know that 18 station is roughly it is 3 hour. If you add the rest station, so maybe 3.5 hours. So it's too much. So we found some student is exhausted at the end. He need to finish the exam, whatever the performance. So the fitness in exam is very important. I think is apart from the knowledge, the fitness is important. Yeah, even the 1 week before the exam, because some students stay sleeping late, and they have a big problem for that. So must be relaxed, because if you found it is stressed or non-concentrated in exam, it is easy to fail. Second, I think is he need to be management of time is the best thing. Usually, no one fail due to lack of knowledge. Usually, he failed because of the bad management of time. Okay. Hello, Dr. Corollos. Dr. Corollos, you need to start anatomy.
Yes, thank you.
Okay, I'm Dr. Shireen. So nice to meet you. So we have a station. First station is anatomy. Second station is critical care. If you have a time, we'll go to pathology. So you can see the slide, or you need to be bigger.
No, I see it.
I see. Okay. So what you have in exam? In exam, we have a picture. This is picture is a fixed. As you see, this is picture is not colored in the way that we have in some books like Grand Atlas of Anatomy. So the artery is not in red and the nerve is not in yellow, or the vein is in blue. So this is a style of picture coming exam. This is all picture is from the exam of the Royal College of Surgeon of England Museum. Whatever the college you enter, it is a fixed picture. This is yeah, two book. If you have a small book, so get through anatomy. If you have big size book like more than A4, so we have Macmillan Atlas of Human Anatomy College. Whatever the college you apply, you can find it is from the what's called virtual museum or something like that. All these slides and some slides appear in exam something called the plastinated. Plastinated means that it is real human, but they treated not like formalin in the past. They treated by some polymers and other, but again have no color.
Okay.
Okay. So what we do in exam? So we give you this picture, and after that we ask you, what is A? Usually we give to you, we don't ask what is A, B, C, D. We just tell you, can you enumerate from A till you finish? So, for example, A is what?
Sternocleidomastoid muscle.
Okay, what is B?
Trapezius muscle.
Okay, I'm looking for C. What is C?
C, it's I don't know.
Okay, so if you don't know, I don't know is better. Okay, D.
I don't know too.
All right. A, B, C, D, E. Where is E? I don't see E. E is here. What is E?
masseter muscle.
Masseter muscle is in F. What is F?
Splenius capitis muscle.
Yes. What is G?
G, it's greater auricular nerve.
Yes, correct. Okay. So if you see these slides, it is look like this. I just back again. Okay. So you see, this is the diagram. Of course, you don't see like this in exam, and this is our answer. So A is a sternocleidomastoid muscle. B is trapezius muscle. C, which is transferred, is omohyoid muscle. D is levator scapulae muscle. E, masseter muscle. F, splenius muscle. Okay. After that, the same also we have G, which is nerve, which is greater auricular nerve. Okay. So back again, what is H?
H, external carotid artery.
Say again. Not is artery, it is a nerve. What is this? H, this one.
Accessory nerve.
Accessory nerve supply which muscle?
Sternocleidomastoid and
Trapezius muscle. All right. Okay. Correct. So after that, we have another, I think, apart from L, K. Okay. Back again. So what is L? What is K? K is here. What is K? This one, in front of tragus, artery.
Facial artery.
Say again?
Facial artery.
No, it is not official. Facial artery is, if you see facial artery down, this is superficial temporal artery. So what you see here, K is superficial temporal artery, and the L, you see L is this. What is L?
Maxillary artery.
Maxillary artery. So external carotid artery have two terminal branches, superficial temporal artery and the maxillary. So which branch, important branch, arises from maxillary artery?
Sorry, which branch?
From maxillary, important branch from maxillary artery. Can cause extradural hemorrhage. Okay. You know, extradural hemorrhage due to what?
Terion trauma? Or
Yeah, it is the trauma. Is due to which artery injury?
middle meningeal artery.
Middle meningeal artery arises from maxillary artery and enters the skull through foramen.
Foramen spinosum.
Spinosum. This is very question. Extradural is important. So as you see, they give you this picture. Just say A, B, C, D, E. You just enumerate. He don't ask you except after that, like I ask you now. Okay. So this is the first. After that, we go to the neck. So this is the area of the neck. Yes. Say again.
I said.
Yes, this is the angiogram of the neck veins, the neck arteries. Big artery is in the neck. Okay, so we started from 11. So what is 11, 12? Just to start from 11 first. What is 11?
I don't know. 12.
Okay, 12. 12 external, what is 13?
Common carotid.
Common carotid. Okay. So what is 5?
A maxillary artery.
Okay. What is 9?
9 superficial temporal artery.
Yes, correct. Okay. What is 4? 4,
Facial
it is
artery.
facial artery because it is corrugated. We only in the body have 2 corrugated artery, like irregular arteries, facial artery and what? In the abdomen. Artery irregular, zigzag like. Splenic artery. Okay, good. All right. So what is 3? 1, 2, 3. What is 1? What is 2? What is 3?
Inferior thyroid artery.
Okay.
Two, I don't know two.
Okay.
Three, I think superior thyroid artery.
Okay. What is 7? What is 8?
7 is anterior cerebral artery. 8
Yes.
middle cerebral artery.
Okay. So I show you the answer. So first down is superior thyroid artery. Second, external carotid artery itself, and the external carotid artery at the end give two branch, which is maxillary, which give middle meningeal artery, and superficial temporal. What is the importance of superficial temporal artery? What disease can occur in superficial temporal artery? Number 9. If the patient have severe headache, what he had? Not common in your country.
Arthritis or great artery.
Yeah, we call it temporal arthritis, and this is artery also is a site you can take a branches for biopsy. So back again, 1 is superficial superior thyroid artery, 2 is external carotid artery, 3 lingual, 4 is irregular, so it is facial, 5 again maxillary, 9 is superficial temporal. What is 6? Is you see 6 here is come from maxillary, so it is middle meningeal artery. Of course, 8 is the middle cerebral, 7 is the anterior cerebral, 10 back is occipital artery, 11 is small. It is very difficult, but 11, this is a tiny branch, is ascending pharyngeal artery. Of course, 12 is internal carotid. Internal carotid have no branch in the neck. 13 is common carotid. Okay, so this is angio for the easy way in exam to ask about the branches of the artery, because it is difficult to have a specimen like this. I show you the specimen, by the way, so you can find the specimen may be somewhat difficult, but we can see the specimen here. This is specimen, this is the ear, and this is the right side of the face. This is the nose, and this is the ear. So what is A, what is P?
Okay, A is facial artery. B
Yes.
lingual nerve.
Okay, so I show you. So A, yes, it is a facial artery. B, it is a branch from the facial nerve. Which branch?
I read it marginal mandibular.
What is happened if you injured the middle meningeal artery?
Middle meningeal artery, extra.
Marginal mandibular nerve. What happened if you injured it?
Asymmetrical smile and the dripping of saliva.
Of the same site or other site?
Of the same side.
Of the same site. Okay. So this, what is the common operation you can injure marginal mandibular nerve?
Submandibular gland excision.
So what is the new guideline to make incision to remove the submandibular salivary gland?
2 centimeter below the mandible to avoid.
You remember my question? What is my question?
What is the new guideline for?
So what you said is the old guideline. So the old guideline or the old incision for submandibular is 1 inch, which is 2.5 centimeters. This is the old. The old means the past. But now, what is the incision for submandibular? How far from the angle of the mandible?
I don't know.
5 centimeter. You know why they make it 4 or 5 centimeter now? Although it is not cosmetic.
To avoid the marginal mandibular.
Okay, so nowadays to avoid injury of marginal mandibular, because it is common to can happen, so now the incision for submandibular is 2 inch or 4 to 5 centimeter below the angle of the mandible, not 1 centimeter. So the 2 centimeter or 1 hand breadth, not 2 finger or something, is the old theory. Okay. Of course, this is not come in exam. It is just for demonstration. So you can see temporal, zygomatic, buccal, branches, cervical branch, all branches of facial, very important, all within the thyroid, the parotid gland. During surgery in England, not in your country, how to identify the facial nerve?
During how to identify facial nerve by their branch.
You remember what is my question? Is not in New York. I don't know where are you from, but
Egypt.
Okay, so for during surgery in England, how to identify the facial nerve?
Uh, I don't know.
What is the easy way to identify a nerve, like recurrent laryngeal or facial nerve, if you are work in UK or USA or Malaysia even? Okay, so yeah, okay, this is why I ask him. So we have,
Trace it and
say again, Mario?
trace it with intraoperative nerve monitoring device.
All right. So it is nerve stimulated is we give the patient anesthesia but no much muscle relaxant, and when they touch the nerve stimulator, the facial nerve, they give contraction of some muscle, so you know that it is the site of the facial nerve. So nowadays to identify facial nerve by nerve stimulator, but if you need traditional way, so looking for tragus and looking for OSCE branch, but now life is easy, so just make nerve stimulation. You can find the parotid gland here and the duct. Where the duct is open, parotid duct.
Second molar test, our second molar
Upper second, piercing which muscle?
vaccinator.
Nerve supply of vaccinator.
Vaccinator, it's trigeminal.
No, my question is what is the motor supply for vaccinator? Because the next question, what is the nerve supply of mucosa over vaccinator? So your answer is the mucosa over vaccinator supplied by buccal branch of trigeminal. But the nerve supply, the motor nerve supply of vaccinator is?
Facial nerve.
Facial nerve, you know that belonging in the buccal mucosa, so it is a facial nerve. All right. So what other muscle supplied by facial nerve?
Stylohyoid.
Stylohyoid, yes.
Posterior belly of digastric.
Posterior belly of digastric, yes.
And
start by S. So we have two S, stylohyoid and stapedius muscle in the ear. So facial nerve supply stapedius, stylohyoid, posterior belly of digastric, and all muscle of facial expression, of course. Okay, and after that they have the buccal branch or the five branch, which is temporal, zygomatic, buccal, mandibular, and cervical. All right, this is okay. Facial nerve again supply stylohyoid, posterior belly, stapedius. All right. So next question: how to differentiate between lower and upper motor neuron lesion of facial nerve?
I will ask the patient to raise by eyebrow. If they can do this, it will be upper motor neuron lesion. If they can't, it will be lower motor neuron lesion.
Okay, so elevation of eyebrow or closer of the eye, if unable, so it is upper motor neuron regions, but if it is unable, so it is lower. What is the common cause of lower motor neuron lesion?
The common cause?
Yes. Which tumor can cause facial nerve paralysis in this area? Malignant tumor of what?
Of parotid.
Malignant tumor of parotid, of course. Okay. All right. From where the facial nerve back come from skull?
Cerebropontine angle.
No, cerebropontine angle, they have it, but he's come from the skull, I think from stylohyoid foramina. Okay. We check it again, no problem. Okay. You know, carotid endarterectomy or operation for carotid body tumor, which nerve can be injured during this surgery?
Hypoglossal nerve.
Hypoglossal nerve. If hypoglossal nerve is injured in the right side, so what happened to the tongue?
It will be divided to the same side, to the right
side. To the same side. Okay, so the first is hypoglossal nerve. So hypoglossal nerve supply which muscle?
Brachioglossus muscle.
Make it general, all muscle of the tongue except palatine supply by vagus. What other nerve related to carotid artery or related to carotid endarterectomy?
Vagus nerve.
vagus nerve posterior, and the third one is okay, can be greater auricular, sympathetic chain posterior, all are related. Okay, so this is the carotid sheath. You can find internal carotid, you can find internal jugular, you can find the vagus, you can find sympathetic chain behind is not present here. Okay, this is also enumeration. So what is the indication why in England they do carotid endarterectomy? What is the indication?
I don't know.
Carotid endarterectomy occur if they have big thrombus but not 100% occlusion. So we call it carotid endarterectomy, sometimes done by local anesthesia, sometimes done by general anesthesia because we're afraid for stroke. All right, so back to the tongue again. Can you describe to me innervation of the tongue?
Okay, by general sensation of the anterior two-thirds of the tongue, it will be by facial nerve, and the test.
No, not facial. Just to make more. You mean?
Trigeminal. Sorry, trigeminal.
No, just relax, doctor. You mean pain and temperature? So it is bilingual nerve.
Yes, and for taste sensation, it will be by facial nerve. And for the posterior third, it will be by...
just a minute, doctor. Lingual nerve and chorda tympani supply the anterior two-thirds. Glossopharyngeal supplies the posterior two-thirds. Okay, this is clear?
Clear.
Okay, so lingual and chorda tympani. Chorda tympani is covered or transmitted through the facial. Glossopharyngeal supply the muscle of the back, pain, temperature, and sensation. All muscle of the tongue supplied by hypoglossal except palatoglossal supplied by vagus. Okay. All right. So back again to the facial. You mentioned when we see the skull, we have something called styloid process. Styloid process have three muscle attached. Can you enumerate these three muscle?
Stylohyoid,
stylohyoid supplied by
trigeminal nerve.
No, stylohyoid supplied by facial nerve. Stylopharyngeal supplied by
Ansa cervicalis.
No, stylopharyngeal supplied by glossopharyngeal, and it is the only muscle supplied by glossopharyngeal, and styloglossal supplied by hypoglossal. So again, three muscle attached to the styloid process. Stylohyoid supplied by facial, stylopharyngeal supplied by glossopharyngeal, and it is the only muscle supplied by glossopharyngeal, and styloglossal supplied by hypoglossal. Okay, so three very tiny bone, just a protrusion, and three muscle attached to it. All right, okay. If you have epistaxis, what is the source of bleeding? Come from what? This is little area, have two artery. Sphenopalatine artery and anterior posterior osmoidal artery, just to know the names. Okay, here is the parotid duct, we'll discuss it. Here the nerve is related to the deep part of the submandibular. Which nerve related to submandibular salivary gland duct?
It will be lingual nerve.
Lingual nerve, okay. So you can see this is salogram. So what is A, what is B?
A, it's a superficial part, and B, deep part of gland.
Deep part and duct. Okay.
And the duct, yes.
Where is the duct open?
Bilateral is the frenulum of the tongue in the posterior floor of the mouth.
Of the posterior floor of the mouth. Okay. And again, this is the margin mandibular can be injured, lingual and the hypoglossal can be injured. Okay. During removal of the upper teeth, which sinus can be affected?
Which cavernous sinus?
No, sinus mean air sinus, not cavernous. Cavernous sinus is not affected. It is like this. If you remove one of the maxillary sinus, so can cause referred pain for that. Okay, so it is very important. All right, so Okay, this is what is the station. This station is just take about 15 minutes or 10 minutes. As you see, he asks you a lot of question, and all this question is just related to one topic. All right. It is okay, but it is important to know. Usually, what we ask is ask something related to the surgery. So we ask about cancer of parotid can cause facial nerve. We ask about innervation of the facial nerve. Innervation of muscle attached to stylohyoid muscle is very, very, very common question because it is funny, and innervation of the tongue is very, very, very important. Okay.
Okay,
All
thank you.
right. Okay, so after that, we have critical care. In critical care, again, it is important to know that in examination, who examine you is not anatomist, it is surgical anatomy. This is exam is surgical anatomy, surgical physiology, surgical pathology. So usually he asks you in the applied basic or applied science more than what we called it, more than proper anatomy or proper thing. Okay. So this is scenario about burn, and the aim of this scenario, because we have a new guideline of the fluid taken for the burn, and this is we insisted for it, and this is important for this lecture. All right. So anyone is volunteer. This is a case of burn, so it is easy, not so difficult. Anyone? You can try Corolus, you can try again. Mohsen Ahmad, if he is happy to speak in critical care, no problem. By the way, from my experience, physiology, we have two stations in physiology. This two station is too difficult station in exam. So if you have bad performance, so don't be sad. Okay. Anyone need to start? We speak about burned patient.
Okay, I can.
Can,
start.
okay. All right. So we can start again. So we show you. So the next slide. This is a scenario. 45 years old woman caught in kitchen fire, rescued by the fire service on arrival to emergency department. All right. Okay. All right. Oh. You can see it now. Okay. So I make it bigger. So, okay. So 45 years old woman is caught by kitchen fire, rescued by fire service. On arrival in emergency department, blood pressure 140 over 80, which is okay. Pulse 125, tachycardia, respiratory rate 25 per minute. Oxygen saturation 95 on the 3-liter face mask. On examination, burn on the whole right arm. Whole right arm mean anterior and posterior. Front of chest and abdomen, front, not the back. There is evidence of soot, mean black color around her mouth and the nose. She is 60 kilo. She is burned. The burned area is locked, erythematous, and painful. So, how to manage this lady?
I will manage this lady according to advanced trauma life support. I will make
Yes.
BCDE. A for airway, B for breathing.
So, can you start by airway first?
Yes, I will check there are no foreign body or something inside the nose. By asking her if she talk, it means clear airway, and if breathing, I will provide her with 100% mask of oxygen. Circulation.
Okay, actually, if you give a patient 100% mask of oxygen, he will die, because oxygen in all hospital all over the world is 60 to 70, because they mix it with the air, not 100. We don't have 100% oxygen in medicine, by the way. No problem. What else?
Advance to white bore cannula and give her fluid.
What you mean by white cannula? What is the color of it?
Green or gray.
Green or gray. What is the size usually? 16 or 18 goes. What else after that? After that, what you give?
I will give her weight and multiply by the size.
So can we wait this till we discuss breathing first? So A, B, C. So we start B, make it fluid in C. So what is looking in breathing? What you do for breathing?
I will listen for auscultate her chest
You
and
auscultate or look and feel and auscultate.
yes, look and feel and
Yeah,
auscultate
by
will provide.
inspection and the feel and auscultate and the percussion and auscultation. After that, the air is okay. So after that, we found this is okay. Based in the scenario, what you consider the depths of the burn?
It will be a second degree burn.
You can see here burned area is erythematous and painful. If it is painful, it is superficial or deep?
Superficial, it means the nerve ending is intact.
Okay, so it is superficial wound, not deep wound. Okay. So how to calculate the area of burn? So back again, how to calculate the area of burn first? How to calculate?
Whole right limb it will be 9%. Front of the chest and abdomen it's 18.
18, so 9 plus 18, so equal to difficult 27. Okay, and her weight is 60. Okay,
60.
so now back again. So how you calculate the area of burns? You calculate it correct. So the arm front and the back 9, front of chest and thorax or torso, chest and thorax is 18, so the total is 27. The patient is 70. 27, weight is 60. How to manage now?
I will give her fluid for according to Barkland formula.
Barkland forma. What is Barkland forma? Tell.
2 multiplied by the weight multiplied by
Yes.
the area percent of the burn.
Okay, so why you make it 2? I agree with you in this station, but what you make it 2?
I really don't know, but
All right.
I know the
Okay.
formula.
All right. Okay. So back again. So this is a formula. The formula is Barkland. Classical Barkland is 4 times total body surface area times body weight. Okay, and half the amount in 8 hours and half the amount in the 16 hour. Okay, this is for any burned patient till 20%. According to the ATLS guidelines, the new guideline, just in the last is the 10 session, so they make it 2. So the 2 is the new guideline for more than 20%. Okay, you understand this idea? We back it again. So after that, we need to test the depths. So we have superficial and deep. So you mentioned it is superficial because of the redness and it is painful. So what is the character of deep burn?
It will be black colored and it will be not painful.
Can be black, can be white, and it is not painful. Why it is not painful?
Because burn of nerve endings, so no pain.
Nerve ending in which layer of skin?
And dermis.
Epidermis, dermis, so it is subcutaneous. Okay, all right. So sometimes we have what is called in the arm or the limb or sometimes in the abdomen what we call circumferential or round or circle burn. What is the danger of that?
It could be make structure over the blood vessels and make ischemia on the limb.
How to manage that?
I will involve multidisciplinary team and I will call my
We
consultant.
don't have multiple doctor. What you mean by multiple disciplinary team?
I mean I will involve many doctors
Are you sure?
related to this case.
Like what? Like what?
Like plastic surgery.
Plastic surgery and
anesthesist.
Anesthesia. Okay. Anyone else?
No.
Go for fasciotomy.
All right. Okay. Thank you, Mariam. By the way, doctor, are you in your hospital? You do that?
No.
Okay. So if you don't do in your hospital until an exam, it is not good. So actually, we don't have multiple disciplinary for burn. It can be for plastic surgery later, but not for acute case of burn. The management of burn is usually not by plastic surgeon. It's a general surgery. Second is when you do fasciotomy or ischorotomy. You need anesthesia or you don't need anesthesia? What is your opinion?
I think I need anesthesia.
Are you sure? You do it before or not?
I didn't before, but I think
You
yes.
did it or not did?
No,
Yes
I
or
didn't.
no? No, okay. You mentioned this patient is painless. So because the nerve ending is cut. So suppose in the upper picture, I just need to cut the 5 centimeter. So you suspected I need anesthesia, local or general, or don't need anesthesia?
No need for anesthesia.
So it's a multiple disciplinary name for you. We don't need anesthesia. We don't need plastic, so we don't need. If you need to ask the help, you can ask the help of your senior, like the senior registrar or your senior in the duty or in the what's called in the rotation, but we don't have multiple disciplinary name. We couldn't have MDT, by the way. Okay. So don't do something you are not in your country, doctor. So this is rule of 9. So what is the perineal area? How many in the perineal area?
1%.
1%. Okay. So if the patient have just a burn in the face, which is little amount, need to be admitted or not?
Yes, admitted because fear of laryngeal edema.
How to treat laryngeal edema or how to prevent the complication from laryngeal edema?
I will admit the patient and I will follow for the patient by oximeter.
If become in stress, what you will do?
Intubation and put him
Intratracheal
on
intubation. But if you are not expert in intubation, what is the fast route to access oxygen?
tracheostomy.
If you don't expert in tracheostomy, doctor, if you are not expert in endotracheal tube, you are not sufficient to make tracheostomy. So what's the easy you can do? You are in emergency, you don't expert in tracheostomy, you fail to insert endotracheal tube. If you need to ask anesthesia, can. But what is the fastest thing you can do? Cricothyroidotomy, because it is just insert a tube in the neck, so it is easy. All right, okay. So after that, calculate the fluid again, back again. The Barkel formula is 4, not 2. But if more than 20%, that's like this patient, due to the new guideline, we make it 2 time body surface area, time body weight, and divide it in 2 halves. First half 6 hour, 8 hour, and second half in 16 hour. Okay. Sometimes in some hospital use another, not Barclay, like Barclay bank. So burned area weight divided by 2 and gives the natural or the amount to come for 12 hour 3 time, 12 hour 2 time, and 1 once. But any equation is accepted. Don't forget the 2 milli, what you mentioned is the new guideline for more than 2%. Okay. All right. So which fluid you can give to the patient?
I will give crystalloid proton
Like-
pump inhibitor.
No, crystalloid like what?
Like Ringer and
Ringer lactate or Hartmann solution. You mentioned proton pump inhibitor. Okay, why give proton pump inhibitor?
to avoid curling ulcer.
You mean a stress ulcer or a stress
Or
from
stress
burn,
ulcer.
curling ulcer? Okay, but it is not a fluid. But you can mention if I ask about medication, what else? What other fluid you can give?
I can
Other intravenous thing you can give.
blood.
You
If
can
there
give
are
blood
bleeding,
if hemoglobin is below what?
below 8.
Below 8. What else you can give? If the patient have loss of plasma, you can give fresh frozen plasma or albumin. Okay. So again, in general, we have ABC management disability on this. After that, in our patient airway, breathing was okay. How to manage? So how to manage later? How to monitor and how to manage?
If the airway not
ABC is okay. B is okay. After that, what you will do?
I will put 2 wide bore cannula for circulation.
All right. Yes. And how to monitor the fluid?
By introduce catheter, urinary catheter to and
Urinary
maybe
catheter.
or by CV pressure, central line.
Doctor, just one by one. You insert a catheter or CVB or just one. You insert urinary catheter. Why?
To monitor the fluid and to monitor urine
You mean
output.
output. You mean
Yes.
urine output, so you make fluid input and output chart. What else? You
I
mentioned
can
central line. What is the value of central line?
to measure the pressure.
What is the
for
normal central line CVB? Central venous pressure?
20 to 30.
20 mean 20?
Yes.
No, 20 is very high. You need a patient in ventilator or right-sided heart failure. So the usually central venous line is 5, maximum 10. What is the unit?
Millimeter mercury.
It is okay. In your hospital, you have the machine to measure the CVB by millimeter mercury or not?
No.
Okay, so what you measure in your hospital?
About urine output for.
No. How to measure central line in your hospital? This is the question.
I don't know.
No. If the nurses tell you this patient central line, Mariam, for example, what is the unit?
Sphingomanometer.
No.
I do column of water, so millimeter of water.
Okay, it is centimeter water, but actually we don't use water, so the correct answer is centimeter saline. So that usually we monitor the central line by centimeter saline because in the rural it is contains saline, so it is called centimeter saline. In some hospital in the Middle East they call this centimeter water, but actually it is saline, not water. All right. Of course, we give the patient oxygen, and again, it's not 100%. It is modified oxygen, 60 to 70. We don't give 100. All right. Okay, next question. 6 days after admission, they become confused, dyspneic, respiratory rate become 28, oxygen saturation become 48 on air room temperature. What is the possibility? 6 days after. You can give option.
Pulmonary embolism.
Pulmonary embolism. Can what else?
Fat embolism. Maybe
Fat
pneumonia.
embolism. Okay, so pneumonia first choice. What else? You mean chest infection? What else? You mentioned pulmonary embolism. For how, if you have patient have pulmonary embolism, it needs how many days to develop? If the patient have DVT 10 days. 10 days. So this is 60 days, so it's not pulmonary embolism. Fat embolism can, but not in burn, can be after intramedullary nerve or fracture femur. So back again. So first is pneumonia. Second,
infection about
pneumonia, chest infection is the same. Pulmonary edema due to bad fluid can. What else?
pulmonary edema and
if this patient have pancreatitis, you have a patient have pancreatitis and she developed dyspnea and confused, what it could be? Acute pancreatitis.
septic shock.
Septic shock can chest infection. What else? Something in the lung. Okay, I choose a chest X-ray. After that, back again. This is a chest X-ray of the patient. What's your diagnosis?
It's pneumonia.
No, it's not pneumonia because it is bilateral. So what it could be?
A cardiogenic shock due to hypervolume.
Back again. So this patient possibility either chest infection, pulmonary edema, ARDS, adult respiratory distress syndrome. So why it is adult respiratory distress syndrome? Can you explain?
Because infiltration and
infiltration is bilateral and
there are emphysema and
it's not emphysema because it is non-cardiogenic pulmonary edema, bilateral lung infiltration, hypoxia despite of oxygen therapy, decreased lung compliance. So if you go to back again, so the patient, you can find the patient is become 84. So it is decreased, 60 days become confused. So if it is by X-ray, it is bilateral. The patient have no cardiac problem before, so it is ARDS or adult respiratory distress syndrome. Decrease lung compliance. What is lung compliance?
It's the efficiency of the lung to have and elasticity of the lung. It can be go in and out the breathing.
Okay, so it is the change in the volume, lung volume per unit pressure change, or something affect expansion of the tongue. So back to ARDS, how to treat this patient?
I will put the patient to non-positive pressure
No, no,
respiration
first, where you treat the patient, where? Place.
in high dependency unit.
So you send the patient to high dependency unit or ICU. What is the difference between ICU and the high dependency unit in England?
Actually, I
As,
don't know.
as regards the nurse distribution, if the patient in ICU is one nurse to one patient, in HDU is one nurse to three patients. So it is the number of the patient, nurses to the patient. Of course, the patient in ICU, his need dependence on ventilator or heart-lung machine or perfusion or dialysis or something like that. So you admit the patient in ICU better. What else?
I will put him on positive airway. I will
What
give
is
him
mean by
steroid.
positive airway? What we called it? PEEP. What is PEEP mean?
Positive.
PEEP. Positive
Yes.
end expiratory pressure or intermittent pressure. Okay. What else?
I will give him antibiotic according to hospital policy.
According to hospital policy or according to your culture and sensitivity?
Culture and sensitivity.
So according to culture and sensitivity, you start empirical according to the hospital policy, no problem. Okay, so you can make blood, sputum culture, prophylaxis antibiotic, empirical till the result is coming. Okay? So
Okay.
this is the end of the station. You know that it is a stressful station, but if you can see, it is not easy, but not difficult. But what I see from your performance, first, don't tell something you are not see in your life. Like I ask for multiple disciplinary team. Many students have believed that we like this word. Actually, we don't know the meaning of this, or we don't like this. So we don't become embarrassed if you see. I will ask for multiple disciplinary team for a burn. You just make sclerotomy or fasciotomy. All right. It is important, of course, to just have a hint about ICU, HDU. Of course, you give a fluid, white bore cannula, all this. I think for you is okay, but if I'm examining you, so from the British culture or the Royal College culture, you look like away from the system, like you are not work in a system. Maybe you are not work in burn unit before, so this is why you are away from the system happened in the burned unit. All right. But you forget something very important. Is this patient is happy or in pain?
In pain, of course.
So what should
Analgesia.
you give him? Okay, so don't forget to anesthesia. Sometimes if severe pain, what type of anesthesia to give to him?
Anesthesia, it will be epidural. Or,
What is common
or
use
BCA.
in your BCA? What is BCA mean?
I remember, but I forget.
Patient control analgesia. What usually put in this patient control analgesia or BCA? It is a pump contain 50 centi of saline and put which medication?
Morphine or synthetic
Morphine. What is
morphine.
the antidote of morphine?
Naloxone.
Naloxone. Okay, so it is important to know morphine. Usually in 50, you just put 10 or something milligram, and we're looking for antidote. Okay, so this is what I know, but it is important. We don't ask a lot of knowledge, but we need you to be within the system. It is important to know how to measure the central line. It is important to know fluid input and output. Okay, thank you, Dr. Muhammad. We have 10 minutes. If you have anything to add, okay, okay. Mhm. Thank you. Thank you. They can choose, no problem, what you need. We can continuous in anatomy and start pathology. So can be anatomy and pathology. So one is station anatomy, one is station pathology. So again, we have two station in physiology. In exam usually is difficult station, but don't worry about that. But it is applied surgery like burn, trauma. So usually is within burn and trauma. Okay, it's again for the others, just to go to the ATLS today, just to see the new guideline for the fluid replacement for burned more than 20%. So the Barkland equation instead of 4 become 2 for 20% or more than 20% or in deep burn. Okay, any question from the candidate, Dr. Nabhan, Dr. Carlos, Mariam, Matthew, any comment, anything?
Thank you very much, Dr. Shireen.
Okay, thank you.
I'm actually taking the ATLS so I can share a bit. So Dr. Sharon is right, it's 2% now because they don't want to overload the patient as compared to 4% in the past. Then one more thing is if there's a circumferential burn, it will be an escharotomy and not a fasciotomy just because of the
Yeah.
anatomy.
Yes. Thank you. I think you finished the ATLS today.
No,
Matthew.
tomorrow.
Tomorrow. Okay, good luck. All right, take care. Okay, so
Thank you,
for
Dr.
me, thank you. Best wishes.
Thank you,
I
Dr.
think
Mohammed.
if you
I
are
have
new,
one
the
question.
system is easy. Mariam, any question?
Yes, so when you mentioned that we don't need to call the anesthesia, so they expect us to answer to this question if they say circumferential burn and what will be your next step. Do I mention it as a bedside escharotomy or like external field escharotomy?
No, just bedside or not bedside, usually done in emergency, just sclerotomy, and the patient don't feel by it.
All
Of
right.
course, in general, you give the patient anesthesia, but not for this. Don't
All
forget
right.
anesthesia, any fracture, any burn, any trauma, you put 2 white bore cannula, give fluid, give analgesia, must be done. Okay. All right. Best wishes to all, and thank you so much. Okay, thank you, Mariam.